Good morning, everyone, and welcome to this special clinical combined rounds on artificial intelligence. We are all intelligent. That is what we think, at least. We get our intelligence in two ways. One is genetic, what we inherit from our grandparents and parents. And the second part is acquired. There is information around us. In our times, the information used to be only in the books, but today it is there everywhere, on your laptop, on your mobile. It is even in the cloud. वो पुराना जो कहते थे भविष्यवाणी हुई, तो that was information coming from the cloud. When we get that information to us, we gain knowledge. And then we apply that knowledge to do certain things in our life, that is experience. And finally, with a combination of all these things, we become wise. And that is why we call ourselves intelligent. Now, people who are in my age, we have done so far, and probably rest of the couple of decades that we have, we will be able to manage with this natural intelligence. We will be able to boast and say that we are intelligent. But most of the people sitting in this hall who have 30, 40, 50, 60, 70, 80 years to go, they will not be able to manage with natural intelligence. You will have to rely on, just as today we rely on artificial food, even artificial air, artificial water, you all will have to rely on artificial intelligence. And definitely, medicine, the way we practice, 50, 100 years ago, medicine was all clinical. Today, it is all investigations. And tomorrow, I am sure it is all going to be AI-based. Unfortunately, we are all AI illiterate, including myself, who am going to moderate this session. And that is why we need to study artificial intelligence. And as we know, all studies start with the nursery school. So today is the primer, where we will learn the ABCD, the AAEE, and Do Duni Char of artificial intelligence. And to teach that, we don't have nursery school teachers. We have the highest level teachers to teach us artificial intelligence. And that includes Professor S.K. Mishra, who's my colleague from my former institution, SGPGI, in Lucknow, where he was for a long time, more than 3 decades, the head of endocrine surgery. But the reason why he is here today is that he was the founder of the School of Telemedicine and Bioinformatics at SGPGI. Single-handedly, he established. Those of us who have seen that center can only believe how it can be done with no institutional support, all grant from government and other agencies. We also have Dr. Namita Mittal, who till yesterday I knew her as the Chief of Computer Science Engineering, but today only she informed me that they have now established a separate department of artificial intelligence, and she is the Chief of Artificial Intelligence at our sister institution in the city, the Malviya NIT, MNIT, as we know it. Thank you, Dr. Mishra. Thank you, Dr. Namita. We also have our own experts, Dr. G.N. Saxena, the former Pro-Vice Chancellor and Principal of the Medical College, who sowed the seeds of telemedicine and bioinformatics in our university. We have Dr. Purvish Parekh, who, when I said most of us are AI illiterate, he is excluded because he knows AI and he is not in the same category, at least I am. So we have a galaxy of experts to teach us, as I said, the ABCD of artificial intelligence. This is only a beginning. I know that this is not going to make us AI savvy, but unless we take the first step, we cannot start the journey. So with those few words about this special clinical combined rounds, I now request our Vice Chancellor, Dr. Achal Gulati, to say a few words.
Thank you, sir. Chairman Emeritus Dr. M.L. Swankar, Chairman Dr. Vikas, Dr. Mishra, Dr. Namita, everyone over here. Naya Naudin, Purana Saudin. What is new must become old one day. Today, artificial intelligence, machine learning may be new. Human intelligence is old. पुराना 100 दिन. लेकिन वो पुराना भी कभी नया था. आदम और ईव के ज़माने में human intelligence was also new. And then over a period of time, it gathered momentum, collected information from all over, and then reached this stage of human intelligence, which was so intelligent enough to bring in artificial intelligence. So that is what the basic concept about artificial intelligence would be. There is no denial that human intelligence is best. Artificial intelligence, however good it may be, is still dependent upon the human intelligence, and it is the man who creates that. It is never an instrument that creates a complication. It is the hand behind the instrument that creates the complication. Therefore, yesterday, newspaper, it was there, during a robotic surgery, perforation was done and the patient expired. Ultimately, what's the cause of that? Is it the robo, or is it the man driving the robo, or is it the intelligence that is fed into the robo? That is what all the progress is going to be all about. We will never be able to replace human intelligence. Artificial intelligence, however good it becomes, it will never be able to replace human intelligence. It will never be able to replace doctors and surgeons and other people. But remember, anybody who does not acknowledge the presence of artificial intelligence will be replaced over a period of time, and that is something which we need to learn. There is nothing known as mechanical engineering, electrical engineering, automobile engineering. Today, what is car? A car is a combination of all the engineering processes turned into a mechatronics. And that is what is required, integrating the various branches and sciences of medicine, channeling them into one particular area for diagnostics, for treatment, for management, and develop machine learning tools over there so that we can progress. The biggest example is Dr. Namita sitting over here. She is head of department or heading the Institute of Artificial Intelligence. Artificial intelligence headed by a human intelligence. So that is what artificial intelligence is, the significance of that. So I'm sure this ice-breaking session is going to go great guns, and it must be one of the watershed moments from where we progress from the nursery school into the kindergarten and going further up. Thank you so much, and all the best for this function.
Thank you, Dr. Gulati, VC sir. Now I would request Dr. G.N. Saxena to recapitulate the history of how telemedicine, bioinformatics developed at our institution.
A very good morning to all our faculty members and to the ex-emeritus chairperson, Dr. M.L. Swankar, our chairperson, Dr. Vikas Swankar, our guests here, Dr. Mishra from Lucknow, Dr. Namita Mittal from MNIT, and all the other faculty members who are present here. In a very short presentation here, I would like to go through the steps that have been taken in this institute even before the word artificial intelligence was, it came into vogue. Now everybody doesn't know anything about artificial intelligence, but they are aware कि ऐसी भी कोई चीज़ है जिसका नाम है artificial intelligence. लेकिन जो हमारे यूनिवर्सिटी है उसने आज से 10 साल 12 साल पहले से वो नींव डालनी शुरू कर दी जिससे हम एक वर्कफोर्स तैयार कर सकें जो आगे आर्टिफिशियल इंटेलिजेंस में काम आए. When I first talked about this institute to our emeritus chairperson and who was the chairperson at that time, the very first word he said, go ahead. आगे क्या होता है इसमें जैसे जैसे होगा अपन बढ़ते चले जाएंगे. And that is what happened. This is, and I'll give you a small roundup of what happened in the last 10 years. The history of digitization and informatics in MGUMST. When, as Dr. Kapoor said, what is artificial intelligence? बात हो रही है आपस में. Are you concerned about the increase in artificial intelligence? But the other person says, no, I'm not concerned about that. I'm more concerned about the decrease in real intelligence. And that is now happening everywhere around us. पहले अपने को टेलीफोन नंबर याद रहते थे सब लोगों के कि किसका क्या फ़ोन नंबर है. आज वो टेलीफोन नंबर को ये भी नहीं मालूम कि 5 डिजिट हैं कि 10 डिजिट हैं. We just look at the name or a code name that we have given and we move on to it. So the steps first started with the first telemedicine conference that was held in the year 2013. The university was founded in 2011, so within a year and a half of the founding of this university, we had our first telemedicine conference, which was major success. And the first point in that conference was, usually the conferences till then were held in either hotels or some other places, but the conference being held in an institute was the first for Mahatma Gandhi, and across Telemedicine Society, this was the first conference to be held here. And it was a great success. We had a large number of people attending it, getting to know what is telemedicine all about, what informatics, as it was called at that time, is all about, and we had speakers coming in from across the world. Then in 2014, Mahatma Gandhi Hospital was selected by the government of Rajasthan as the nodal center for providing telemedicine consultation. And this was something for the first time again to a private institute. Earlier, the government institutes, the district hospitals, the medical colleges, at that time there were 6 of them, the 6 government medical colleges and 30 district headquarters were part of the telemedicine setup. But in 2014, the government made an exception and made Mahatma Gandhi Medical College and Hospital as the nodal center for telemedicine consultation. Then we held a conference, which was the American Health Information Management Association conference in October 2015, which was again located in Mahatma Gandhi University. And this provided an opening for the international faculty to be aware of what is happening in our institute. Then in 2016, the government of Rajasthan, through a private agency called the Global Healthcare, again made Mahatma Gandhi Hospital as a hub for consultation for Rajasthan Telemedicine Project. In fact, they bypassed the government setup, and we were having as many as 500 to 700 consultations per day, and majority of them in skin, gynae, and radiology. So that was the beginning, and that's what जैसे कहते हैं tsunami सी आई telemedicine की. और उसके बाद we have established an institute of health informatics, Mahatma Gandhi Institute of Health Informatics, and you can see the boys here. They are being trained. They are the workforce that will come in handy, because they'll be the persons, when we talk of computer people, with due regards to Madam Mittal sitting here, that the engineering faculty is aware of the technical part of it. The medical faculty, for people like me, we are aware of our medical sciences. But the interface, where we have people who are aware of both the things, is the workforce that is going to affect all of us. And we are proud to say that in the state of Rajasthan and in northern India, we are the ones who will be providing the workforce for institutes like this and for the coming merger of the medical and the artificial intelligence fields. Then in 2020, we had an international conference on applied health informatics, where we also had, the venue was our R.L. Swarnkar Auditorium, and it was on the 11th and 12th January, where we discussed not just about the applied health informatics, but also the development of curriculum for the various courses that were being held, not just in our Jaipur, our state, but also across the country. Then again, in view of the high performance and excellent work, Mahatma Gandhi Hospital was selected by Madhya Pradesh government for online consultation, where patients from 550 centers were benefited. And then we fine-tuned the thing, that instead of calling the doctor to the telemedicine center in our hospital, we established the telemedicine nodes all across the tables of the consultants, so that they won't have to move from one place to the other, wasting their time and the time of the patient across, which again was a big help. So we had nodes sitting at the tables of our professors, and in cardiology, pediatrics, skin, where they could give the consultation without having to move to the telemedicine center. Then again, this picture shows that there is a workforce development in digital health. We had a program in which we had various people coming in from outside the country and from within the country. The Telemedicine 2019 conference was held in the Indian Spinal Injury Center, and our chairperson, Dr. Vikas Swarnkar, was there. Dr. A.K. Singh, again one of the founder members of telemedicine and health informatics for our institute, were there, and we could establish a good rapport with a large number of people. The telemedicine services during the COVID phase was actually the coming of age of telemedicine. Before that, there were always legal issues, there were problems with कि अगर कोई गलती हुई तो कौन जिम्मेदार होगा, क्या होगा. But the force of the epidemic of COVID turned the tables, and telemedicine then became mainstream. And not only in Rajasthan, But in the entire country, the big centers, there were many major players, the big corporate hospitals developed telemedicine platforms of their own. And in our center, in Mahatma Gandhi Hospital, we were providing free teleconsultation across WhatsApp calls. We had physicians, gynae, gastrosurgery, general surgeons, pediatrics, optho, ENT, cardiovascular, skin, you name them, and we had them available on telemedicine across the board. Then we had an ICD workshop coding, in which again we had a large number of people attending. That was on 8th March in 2022, which was attended by large people to understand the mechanics of ICD-10 coding and to use it in our informatics center. We sent our students to All India Institute in Delhi and to CDAC Center, the health informatics students, so that they could be aware of what is happening outside their own institutes. And the interesting thing is, when they went there, the people who were in charge of the telemedicine, the informatics in All India Institute and CDAC offered them a job there itself. कि आप तो जैसे डिग्री हाथ में लो हमारे पास आ जाओ, we have a job offer for you. Some of them, because of their own family circumstances and their ability to live in big cities, did not join, but the offer was there. And from places like Bangalore, Delhi, they still have an open offer. यहाँ से जो pass out करता है, graduate करता है, he has an open offer of joining any of these nationally and internationally known centers. Then we had a workshop on the health informatics curriculum development. Then we had a faculty development program on ICD and SNOMED CT. Then just recently, in fact last week, we have signed an MOU where Mahatma Gandhi Hospital will be having a tele-ICU, which is a technological innovation to bridge the gap in critical care. Our critical care specialists and our physicians and our trained persons will be giving teleconsultation for ICU services to at least 3 hospitals round the clock, and we'll be on the board of their clinical rounds, and whenever there is a call from there. Now, what is the near future we are looking forward, and it's not too far, is the Mahatma Gandhi Institute of Digital Health, which is going to be again a forebearer of before other institutes come up. We'll have a digital health institute which will cater to the workforce coming up and to sensitize the medical students, the nursing students, the dental students to the use of artificial intelligence and other diagnostic and therapeutic tools that are likely to come up. Thank you very much, and looking forward for a day of an hour of learning about artificial intelligence. Thank you.
Thank you, Dr. Saxena sir, for taking us through the journey of telemedicine and digitization at our institution. Now I would request Dr. Namita Mittal, who, as I mentioned earlier, is the chief of the newly created Department of Artificial Intelligence at MNIT Jaipur, for her presentation. Dr. Namita, please.
Good morning, everyone. Respected dignitaries and dear students. So first of all, I would like to thank organizers who invited me here. And it's my dream come true that I'm here with such a intellectual group. So the time given to me, I'll covering all these in a quick manner. So first of all, we'll start with I'll correlate with the intelligence, artificial intelligence with the machines. So why we have machines instead of men? The fatigue, human error, shortage of experts, emotion-free creativity. Nowadays, generative AI is there that makes the creative things. Apart from that, the issue with the men is environmental risk, physical safety, psychological stress, disease exposure, cognitive overload. Everyone knows about it. So we replaced men with the machines because it was needed. Now, artificial intelligence came, and then it refers to the simulation of human intelligence processed by computers. Importance of AI in the field of medical has the potential to create healthcare by aiding the diagnosis, treatment planning, radiology, drug discovery, and patient care. So today we'll be seeing all these by the different speakers. So basically, what is that essentially make AI needed? The AI systems aim to replicate human-like cognitive functions such as learning, reasoning, problem solving, and decision making. So question came, can machine think? it came in 1950. Nowadays, I can say that yes, machine can think, but the question is, they cannot do anything without the men. We have to provide them the intelligence. So only we want machine to learn such a way that they react as an intelligent person. So AI algorithms, those are the programs, we do coding in computers, are designed and implemented to analyze vast amount of data. That is necessity, that we should have a data that is validated data, that can recognize patterns and make predictions and decisions based on the information provided. So we have to believe on the data. So once we get the data, we have to validate it, we have to pre-process the data. So as sir asked me, what we mean by this different kind of areas of AI, these are mainly machine learning. Machine learning, if you can see it from the slide, that first is a AI, that is a big umbrella, and under this umbrella we have machine learning and deep learning. Looking at this, this one, this is artificial intelligence. We say engineering of making intelligent machines by the programs. But later, that is not enough. AI is not enough. We have to go inside it. That is machine learning. So ability to learn without being explicitly programmed. We say, this is my input, this is my output. Now you do whatever you do. That machine has to do it. This is my input, this is my output, and you have to make a model. For example, if I say y is equal to f of x, f is nothing but a function, and x is a parameter, we get the y. So what is this fx? That is a model. So we say, this is my x, this is my parameters, and this is my output I want. What is the model, f of x, that the function, that is done by the machine. So that is, even that is not enough. We have to go inside that. That is a deep learning. So learning based on the deep learning neural networks. So looking at this machine learning example, if I have this type of data, this is just a hypothetical data, and we can have lots of, these are the we can have 6 million instances. These are the maybe 6 million, or these are 4, 5, 6 parameters. These may be the 6,000 or 60,000 parameters for something to be detected. So looking at this data, we can say first instance is benign. This is a data of mammography. And second is malignant, benign. So somehow these are... Sorry for that. So these are not enough. So first of all, we have to find the prominent features. Those are needed for this label. Label is nothing but your Y. Y that is to be predicted. So first we have to make the model prepared, and that should be trustworthy. After doing lots of training, then we find the accuracy of the system. If it is good enough to take forward, then we say we start testing. Then again, at the time of testing, we ask the domain experts to validate it. So the thing is, as sir said, without human intelligence, artificial intelligence, nothing. But artificial intelligence is needed because the domain expertise are less. We cannot do 24/7. That is what machines are doing, and lots of other factors also that made the artificial intelligence. So if we say that these are the number of instances, these are the number of data, and that is to be pre-processed. That is important. 70% work is done when data is pre-processed. What we mean by data pre-processing? The noise is to be removed. The outliers are to be removed. The debris, for example, if we have something in the images, debris is to be removed. And the pattern is to be recognized from the data. So here I have written that y is nothing but f of x, and f is model, x are the parameters, and y is our output. So A1, A2, A3, these are nothing but your parameters. We have to find the prominent features. Prominent features, for example, in this data, somehow if I write the weight of a person, or a height of a person, or a color of a person, doesn't make sense. No need of that. We need only the important, because it needs the computation power. We have to optimize the computation power. That is what machine learning is doing. So what next in terms of deep learning? Deep learning is consists of internet nodes that is the depiction of a brain. So here we say this is input, and this is how we channelize, and ultimately we reach to the output. So same thing we do in the machine deep learning. Then x1, x2 are nothing but the input parameters. These are the neurons, and we do some kind of weights and programming, hidden layers, activation layer, as the brain does, same thing we mimic here, and ultimately we reach to the loss function. If we say 90%, 95% has been achieved, so 5% is a loss. Is it affordable? That we have to check it. If it is okay or no, we are not happy with that, we have to again formulate it, again remodel it, and say 99.5% has been reached, but still we have to endorse it by the domain experts. So that's why of course, machine intelligence is nothing without the human intelligence. So if we are not happy with this, then we back propagation is done, we retune it, and again keep on doing it until unless we reach to the threshold and we are supposed to reach. So as we have seen, main task in sir was asking, what are the main tasks of AI model? Classification. It classifies data into predefined categories or classes, for example, benign or true or false, gender may male, female, something, whatever. These are the discrete categories. We cannot go beyond that. If it is there, the Y is discrete, fixed, red, green, blue, fixed, positive, negative, fixed, then it is known as a classification. If the data is coming, output is coming in a continuous flow, like estimating patient survival rate, this is continuous, it cannot be discrete, then it becomes regression. And this is clustering. If we don't have the human expert, looking at this, here the classes are discrete. There are two classes only, benign and malignant. It means this is known as a supervised learning. There are some supervisors, there are some teachers, there are some guides. They are telling us that this is the thing when the answer should be benign. This is the thing when answer should be malignant. But what if we don't have expert? Then it becomes clustering. We don't have the supervisor. That is known as a unsupervised learning. That is known as a unsupervised learning. So all these three come under machine learning. The next is, that is a new thing, is a generative model. It creates new data instance. If I had only 6 data here, but I need more to validate it, the data can be generated using the same data, putting some noise, putting some debris, putting some clearing, and we can generate the new thing that is not available so far, that is known as generative AI. You must have gone through ChatGPT. ChatGPT is created in November 22, and since then life transformation has been has come in lives of many, and this is an amazing thing. It is commonly used to creative applications such as generative art, music, text, and chatbots are the example. So AI contributions in medical in terms of what engineers, software engineers or AI engineers are doing. Analysis of medical images for finding any abnormality. So first we should know what we mean by abnormality. We need to train the machine that this is abnormality, this is we keep on saying, as we do, we keep on saying to a child that if you do like this, you'll fall away. If you do like this, you'll continue, you'll be given a reward and penalty kind of thing. That is known as a reinforcement learning. So ability to look at the trends in the patient biomarkers to aid in the early detection of disease and warning, alerting the clinician. That is also possible, and MNIT, means in my supervision, one of the PhD student had worked it, and we had file a patent. Predict disease outbreak and patient outcome by analyzing huge population health data. That has been done in COVID. Chatbot and health assistants are very effective in answering basic patient queries and provide them with immediate access to information, including guidance on healthcare issues. Like nowadays, there's a term, or that is every third person in terms of students, every third student is having some kind of a depression. So the therapist is needed, like a counselor in the universities, right? So the problem with this human being, that they are not affordable, means they charge, they are not accessible, and some kind of a privacy. Students don't want to share their problems. So what if we can have an AI therapist in terms of chatbot that is available 24/7, affordable, and can be the data can be shared with them, and that is also confidential. Remote patient monitoring, where the data is tracked by AI to observe any can be done through telemedicine as well. And we have worked in COVID as well through this telemedicines. So these are the applications: disease diagnosis and prognosis, drug discovery and development, personalized treatment plans. Every person has a something unique, that is through genetics. So that is to be, medicine is not fit for all, right? The elements or treatment is not fit for all. It's not, that is to be personalized. To going deep inside till genetics, then it may have something better idea. Medical image analysis and interpretations. AI can automate medical image analysis tasks such as detecting tumors in radiological images and segmenting organs for surgical planning. This is also possible with the use of AI. These are some tools available for the medical field. Many hospitals, many doctors are using it, or even non-doctors also using it. Marato, it is made by IBM Watson Health. It is the oldest one and it's doing great. Analytic Curie, Regard. And apart from that, we have a natural language processing and healthcare environment. Natural language means it has a two part. First we have to understand, and later we have to generate NLU and NLG. So whatever I want to write in my language, because everyone is comfortable in their own language, right? So the same language can be conveyed, and that is to be understood first, and the output is to be generated. So AI-powered therapy apps and platforms are also available. People are using it. Wobot, Replica, Talkspace, they offer emotional support. The emotional support is not available in the machine. But thing is, we want machine to learn such a way that they start capturing the emotions. He's a happy, he's a sad, he's angry. That is the thing that AI is needed actually. So how do we do it? This is our area actually in NLP. User input, the data is pre-processed. 70% work is done when data is fully pre-processed. Then intent, what is the intent of the user? That is to be detected. Then dialogue management, the conversation, and then machine learning or NLP is applied, and then user interaction. That is what being done in the chatbot, right? So these are the trends in AI in medicine. Google DeepMind Health is available, Microsoft Healthcare Bot. These are very giant vendors, and they are doing well. NVIDIA Clara, a platform that accelerates healthcare AI with advanced imaging and genomics. Apart from that, GE Healthcare Edition, Olympus, that is a recent one, that platform powered by AI that includes endoscopy application, EndoAid CAD, computer aided detection for the colon. So everyone has gone through ChatGPT, I suppose, and ChatGPT 3.5 is a free, and ChatGPT 4 is a paid. And in ChatGPT 4, there are some features. Even we can generate our, as a non-medico, you can have cartoonies yourself, photo multiverse, logo creation, everything possible. Even the design or slides making or email writing or summarizing of a document, everything is possible with, it saves the time. It saves the 2-hour work can be done in 10 minutes or 20 minutes. These are the recent version of ChatGPT 4. And what are the challenges being engineers or being AI persons we are facing when we work in this? The data set is not available. That is the first thing. Then domain expert, without that AI cannot do anything. The privacy issue with the data, and the legal issue, of course. Kuch ho gaya kisi ko to kya hoga, something that is to be validated. The way forward, AI offers transformative potential in the medical field, enhancing diagnostic accuracy, personalized treatment plans, and streamlining healthcare workflows. Its integration promises to revolutionize patient care, improve outcomes, and drive innovations in medical research and practice. And MNIT is working in all the medical domains using AI. We have we have a team. Those are doing cancers one and many other things. So we are happy to collaborate. The way forward in recently, the call for proposal has come, and that is AI Center of Excellence. There are 3 main areas, and one of them is a healthcare. And 300 crores will be given to the vendor, and prospect vendor is AIMS Delhi. They have applied, and they will be working in all the platforms of like screening, diagnosis, chatbot conversation, and everything. So people have applied, 55 vendors have, like institutions have applied, and they will be getting it. One of them will be getting it. So this is all about the time given to me. These are the references. I'll be sharing these slides with everyone. They can just Google it. And so if you have any question,
We'll take the
your questions later.
Thank you, ma'am. Thank you very much. I think we'll take the questions in the end. In your last slide, you said challenges. So one of the challenges probably we can cover because we have data sets, and I look forward to more interaction between our institution and MNIT to explore these areas further. Now I would request Dr. Purvish Parekh to tell us what role AI can play in medicine in general, and what has been done so far.
Thank you very much, respected Chairperson Emeritus, Chairperson, other dignitaries. So whatever Dr. Mittal has said, I would like to, talk to you in a very pictorial form, okay? So my first question to the audience is, did anyone of you come and bring your computer with you? Raise your hand. Okay. And how many of you have come with your smartphone? Raise your hand. So the first lesson to all of you is that this is not a smartphone. It's a computer, which also allows you to make a phone call, right? So that is the most important thing that we can learn from today. Now what do you see here? I'm going by Uber to the airport, and you can see that it is showing different locations where the car is there. But what do you see in the brown box up there? The brown box says location sharing is disabled. In spite of that, it is still tracking what I'm doing. Another example, I'm going to a new location, I'm walking, and I want to see, because it's evening time, I want to see what is in the surrounding area. So I'm turning my phone right and left to see what is happening. And in this instance, while the location is on, both the mobile data and Wi-Fi is off. Still, it is showing me where I am. So ladies and gentlemen, please understand that smartphones are spying on us since at least 2018, okay? Whether it is on or off. And that is why Uber takes advantage by machine learning to decide the price that we will pay based on the battery left in our phone. Okay? If it is 84%, they are charging less. If it is 12%, they are charging more. Okay? Please make sure your battery is full before you book an Uber. This is why data is never sleeping, okay? The internet is full of data all the time. 65% of the world's population is using data. And the data that is consumed annually is in zettabytes, okay? Zettabytes. So what does that mean? This is the reason why Amazon sales every minute is $283,000 US. So by the end of this CCR in 1 hour, Amazon will have sold 144 crores of amount of goods to us. So we should understand, and on the right-hand side you will see that we do a program on the second Tuesday of every month from 7 p.m. on Zoom. It's called Oncology Beyond the Obvious. And what you see is an iceberg. And the large part of the iceberg is under the water. So also it is true for the internet. we are only looking at the surface web. Below that is the deep web, and below that is the dark web. So Google, what we commonly use, Google Chrome, only looks at 5% of what is on the net. And this is 19 terabytes. But actually 7,500 terabytes are in the deep web. And as far as the dark web is concerned, we don't know what is going on because it is full of things which we cannot access without special tools. As a result, there are lots of frauds. Fortunately, in this instance, Flipkart and Paytm refunded the 20,000 and 3,000 that the person had lost. But even so-called very smart people lose money to frauds on a daily basis. Now, if Mr. Maran has lost 1 lakh rupees, it's like a drop in his ocean. But for you and me, it is very, very important. So please remember that today I can use free tools to access your computer or your smartphone from anywhere as long as it is connected to the net. And therefore, you should be really scared of me, even though I'm not an hacker. Now, these are some of the articles that we have written, and all of you have used ChatGPT while communicating with your colleagues, right? Now, ChatGPT is better at answering patients' questions. ChatGPT's answers are perceived by patients as being more empathetic, more humane. So please be warned that our jobs are already threatened by artificial intelligence. Now, madam also mentioned about colonic screening for colorectal cancer and how artificial intelligence is used there. So this is one such instance. You can see that blue box, which makes the operator, that is us doctors, look at a possible abnormality and therefore saves time. Now, this picks up adenomas by 20%, which we would have otherwise missed. And a meta-analysis of all randomized clinical trials of artificial intelligence in colorectal cancer screening shows that there is a 47% increase in detection of cancer. 47%. And you see the forest plot, everything is in favor of artificial intelligence. Now, this is histopathology, and again, madam said, we have to remove the debris. But that is the limitation of human intelligence. In this particular instance, the histopathology is on the left side, hematoxylin, eosin stain. In the middle is how artificial intelligence paints the histopathology. And you can see that there is debris, there is muscle, there is mucosa, in addition to the tumor under consideration. And machine learning identifies that stroma is an important factor. Not just the tumor, but the stroma is also important. And it divides the tumors into stroma low and stroma high. And this is the correlation with survival. Stroma low is highly statistically significant, better survival in our patients with colon cancer. Another example, and I must warn you that this is a preprint. It has not undergone peer review. It was put on the preprint server in December 23. So that is the rider on this. This analyzes the shape of the cell. On the bottom left-hand side, you can see this is the normal cell, this is a round cell, this is a compressed cell, and this is an irregular cell. And it tells us that the shape of the cell predicts what is the genetic expression of the tumor. In other words, ladies and gentlemen, NGS is under threat because anatomy analyzed by artificial intelligence can give more information than NGS can give. And if you concentrate on the top side here alone, you will see that this is the RNA expression, this is the DNA and the protein expression, and the third part is the cell interaction, how adjacent the cells are to each other. And when you put all these three together, you get a gene expression profiling that is even better than NGS. You must have heard of Neuralink, right? Elon Musk is putting a chip into the brains of human beings. This was reported on our television as well. And this is data from yesterday, 20th February 2024. The first patient in which the chip was put, is able to control the computer mouse just by thinking about it without using any of his limbs. You might say that all this is outside India. Ladies and gentlemen, that is not true. If you do a PubMed search, artificial intelligence, colorectal cancer, India, you have 58 publications. And Dr. Mittal, therefore, you are not alone. A lot of people are working on this. And if you want to collaborate internationally, I would recommend that you sign on GitHub. And this is an open access community, online community, where we can interact with any expert anywhere across the world. Now, why is this important? 500 Fortune 500 companies, 92% are using artificial intelligence. And why are they using artificial intelligence? It's where the money is. The maximum wealth in last year was by artificial intelligence using companies. And therefore, Bloomberg has started an artificial intelligence index to track all the shares of the companies which are using AI for their business. Using AI is not cheap, okay? OpenAI spends 5.7 crores every day to provide ChatGPT to us, okay? 5.7 crores every day. And therefore, it is arrogant. When Sam Altman came to India, he said, India cannot make ChatGPT. And fortunately, Mr. Mahindra said, challenge accepted. Sam Altman's OpenAI may have a valuation of $86 billion, but Reliance Industries alone is 3 times the value of OpenAI. And as a result, ladies and gentlemen, we also have Bharat GPT that is available to us. This was developed by CoreOver AI. And this is the sort of information and systems that are made available to us by CoreOver AI. So if the Polish wine company has a CEO that is a robot, India is not far behind. ISRO has the Vam Mitra, which is a female astronaut that is going to be sent up in Gaganyaan mission. So if this is the future of artificial intelligence, what should we look for in healthcare? And my favorite person is David Shapiro. And he says that artificial general intelligence will be available to us by September 2024. This year, in 7 months' time, this is going to be available. And when this becomes applicable, the only thing that us doctors will do is to look for prevention of diseases and increase longevity. So what is longevity? Time magazine and National Geographic feels that we are going to live for so long. And this could be similar to what we have seen in our Shastras also. Lord Krishna, for instance, was alive for 125 years, 7 months, and 8 days, right? But Google wants to solve the problem of death. He says, why? Death is a disease, let's get rid of that. And that is like doing the Pran Parishta. Lord Rama was alive for 11,000 years. How was this possible? This is possible if the pran or the soul along with the memory and the mind is downloaded on a pen drive and then uploaded on another body. So you can transform from one body to another, and that is what we call rebirth, right? Now rebirth requires bodies, and Ectolife is able to produce 30,000 babies artificially every year. So there is no problem in getting a new body. We can continue to live for as long as necessary. So ladies and gentlemen, welcome to the real world of artificial intelligence.
Hello, this is the AE avatar of Dr. Shashi Tharoor. Dr. Tharoor, it's a pleasure to have this conversation with you. As someone who has often articulated the complexities of language and communication, I wonder, were you surprised when you first learned that an artificial intelligence model like myself could engage in conversations and even emulate the nuances of human discourse?
Yeah, sure, I was surprised. I mean, there's no question that, one reads about these things in science fiction, but you don't really expect to actually not only...
So I'll leave you to look at the whole video a little later.
Hello.
But I would like to end by thanking you. And this image was also created by DALL-E. Thank you very much.
Thank you, Dr. Parekh, for giving us a real-life, practical, easily understandable view of what artificial intelligence is. वो पुरानी कहावत होती थी कि उसका दिमाग भेजे में नहीं टखने में है या घुटने में है. That was done as a sarcasm, but it may become true because I may get the chip implanted not in my brain but in my knee. So then my dimag will be in my ghutna. So now I request my former colleague, my friend, my next door neighbor at SGPGI Lucknow, Dr. S.K. Mishra, who was the chief of endocrine surgery for more than 3 decades and the founder of School of Telemedicine and Bioinformatics at SGPGI, for his presentation on what role this new science is going to play in surgery.
Thank you, Professor Kapoor. Respected Emeritus Chairman and the current Chairman, Vice Chancellor, Pro-Vice Chancellor, Dean, Dr. Saxena, faculty members and students. It gives me great pleasure to visit this institute after 10 years, exactly, little after 10 years. 2013 I was here. That's the first time I got introduced to the Emeritus Chairman. That time he was the Chairman. And I could see his vision, and I could see this institute has transformed after 10 years. I don't find any place I can recognize different buildings. That's fine. And moreover, I want to give the compliments to him that to visualize that you want to set up Institute of Digital Health, which are very keen to my vision also. I have been trying to convince some of the state government to set up this digital health. After realizing the telemedicine has just become a small molecule inside the large arena of digital health. So today, we talk of digital for everything. Anything. I think youngsters, we call it Generation Z, I think so. Generation X, Z, I don't know when. Somebody asked me what is there next to Z. I said Z plus 1, something like that, we don't know. So that is the thing. So I thought this particular presentation, as a surgeon, I want to share with you that how I have experienced this technology over the last little more than 2 decades. And I never thought that this area is going to really expand so much and will last beyond my lifetime. Next question. Okay. So I have highlighted some of the important points for you in the red, so you don't have to really concentrate on the whole slides. And of course, the slides are going to be available to you. You can see it in the leisure. I'll be a little faster because of the shortage of time. As you know that as a conventional surgeon, we never really thought of that we have to know about this new technology in our late years of our practice. But that's the evolution. So when we started with many of the landmarks that has influenced the course of surgical practice. Just time before us, that is the antisepsis, then the instrumentation, then the various kinds of images. Let me tell you the youngsters, when I got my residency surgery without even seeing a CT scan picture, or ultrasound was not there in fact. So now you see in a drop of hat, you advise all this investigation at the first point of contact with the patient. The so-called industrial age, we saw the golden age of surgery, where you find the anesthesia discovered, antisepsis, X-ray imaging, dedicated operating rooms, formalized training programs, etc., etc. And the information has brought out a different connotation, that digital imaging, invasive monitoring, electronic medical records, laparoscopy surgery, which is totally based on the chips that you see by bits in the screen. And the end of transition is to an entirely information age surgical system, that is robotics or computer-aided surgery. Now, many of my presentations will focus on the digital surgery, so kindly just focus on that. The term digital surgery is widely used within the specialty, despite meaning of the term very unclear. There is a consensus developed all over the world to define what is digital surgery. So at the end, I'll give one slide so they've defined what is digital surgery. But today, you can understand yourself. We are practicing digital surgery day in and day out. This technology's nomenclature needs to be standardized to have a safe and effective translation into clinical practice. It is impossible to quality assurance of clinical interventions and trials without this. Also essential that digital surgery can be explained to patients clearly and consistently, especially in context to data collection and processing. Today, I'm talking of all AI, so all my presentations are taking towards laying foundation for the AI, because AI is based on the data. Lack of clarity surrounding digital surgery impedes process. In this rapidly emerging field, there is a need for research priorities and areas of collaboration to be clearly identified. In that context, I want to appreciate this institute that you are visualizing this develop such kind of infrastructure so that you can really do a lot of research in this area, which is not happening in our country. And we need that convergence of the minds of the technologists as well as the physicians. I think the madam is here, so you can really discuss and find out, make cohesive groups. Finally, surgery is a high-risk clinical intervention. We have just told, I think Vice Chancellor has just said that there is a problem with the robot, and who is to be accountable? Obviously, to the surgeon. So you should realize that it is the robot-assisted surgery, not robotic surgery. At the end, we are responsible. So now, I told you about the consensus of what is digital surgery. The use of technology for the enhancement of preoperative planning, surgical performance, therapeutic support, or training to improve outcomes and reduce the harm. Every word matters in this definition. And whatever you have been hearing today in the morning session is surrounding this. So we are involved in the entire patient care flow, from the beginning to the end. So everywhere, you call it artificial intelligence, but that is a primer. I'm talking about the developed infrastructure to gather the data so that you can teach the patient, you can explain to patient, as you just heard, the ChatGPT and or you do AI pods, they explain to the patients. We don't have a time to explain to the patient. So they can explain to the patient what is a gallbladder surgery, what is a laparoscopy surgery. Now today, a surgeon, it is just like sitting on the workstation. When operating a laparoscopic surgery, or image-guided surgery, or robotic surgery, you are looking at the screens. You don't have any idea about the flesh and blood in one hand. So you are working in a workstation, and so we live in the world of IT altogether, looking at the screen and manipulating the hands, and even if I'm manipulating with the endoscopic surgery, it is still manipulating your instruments or a robot. And the data you accumulate so fast, you don't realize that. And this data is very valuable. And this data needs to be captured. I'll just show you some of my slides, how to gather the data, you have to have the infrastructure. In medicine, this information age has resulted in the increasing need of data manipulations. You just heard Dr. Parikh, this is how data is getting manipulated in a good way and a bad way also. But in surgery, it is very important to plan and to perform surgery. The surgeon can be guided during procedure that you are doing wrong. This is not the way you should do. That's called AI integrated operation theater. The scope of information age surgery includes the growing field of surgical robotics, which is leading towards the integration of multiple technology present in the operating room into a single console. I mean, we are thinking of a thinking computer, the cognitive power that computer is given. The microscope, endoscopes, surgical navigation, imaging devices, everything is guided to that kind of cognitive process. These devices produce an array of sophisticated data set. It optimally used could greatly facilitate the performance and safety of surgery. This is the time actually all the leading institutions should think, or Professor Vinay Kabra just said that we have enormous amount of data. How can we store the data? It's a big challenge for the hospital administration. Huge amount of investment has to go into that. The next step in the technological integration represents a fundamental shift in the way the surgery will be performed. The surgeon will relocate away from the operative site. That you must have heard about the telesurgery or telerobotic surgery, whatever it is. A remote workstation will enable the surgeon to conduct an operation while manipulating the technology present in the operating room. It's of course very expensive venture. It is being practiced in very few locations like in Canada where Newfoundland is not accessible to the mainland. This is the thing that we created at Lucknow in a GPJ. So if you want to really capture the data, so you have to integrate all your devices. If you want to practice image-guided surgery or robotic surgery, you should have this kind of setup. Those you visualized, and you got a grant to create one of the operation theater. And we created this operation theater with a grant from the government of India. And if you have seen, Dr. Kapoor has already seen that, this is integration of multiple devices. Nobody ever thought that ultrasound will be inside the operation theater. Today, why ultrasound? We have got a C-arm, we got number of equipments. They are unconventional practices many decades ago. Now they are all in the operation theater. Now just imagine all these inputs coming from different devices needs to be integrated to a single pipe and should be visualized whether it is a surgeon console or it is a operation technician control or it is a centralized devices control where the PACS images and the surgical data are being transmitted. So this is the theater that we created at the Lucknow. Unfortunately, this theater got burnt recently. You might have heard about that. So we lost about 13 crore rupees in this process. This is the practice I did about 10 years ago, and many of you must have realized, you must have practiced yourself also. What I used is put a head-mounted camera. It's called motion camera. You might have seen these pictures of the skydivers. They see the motion camera and take the pictures. So this I used to capture the image of the operating procedure and mentoring this thing on a tablet, and in all the steps of surgery, just guiding them and pointing out different anatomical structures and transmitting remote locations. This is all possible. Even you can use it in your own mobile phone. This is idea I got it just to see that can we guide a birth assistant in the primary health center or community health center, just allowing her to put this camera, and remotely one trained gynecologist can monitor the process of birth or any other procedures in this hospital or a small hospital. Can the surgeons here in Mahatma Gandhi can really guide them? It's all possible. Today you have got the 5G network. Tomorrow 6G is coming. So all these things are possible, and you might have heard about the satellite-based internet. 3 or 4 companies are already in the venture. You will find the remote areas where deserts and all hill region is accessible to the high-speed internet, which is not there many years ago. So this is all possible, doable. You can do it. Only your thinking matters, how far you want to go. Now, what should be the attitude of the information age surgeon? Obviously, you have to prepare yourself mentally, physically, not so much physically, at least mentally. Surgeons grown up in information age should get, this is for Generation Z surgeons, should get access to the digital knowledge. All of you are digitally literate, I hope. They expect the electronic medical record, the DICOM files. Today, you know, DICOMs are not all DICOM 3. There are many DICOMs, variety of DICOMs files. All these things are, any radiological investigations has to be converted to DICOM files so that it can be interoperable. Immediate access to the online information will allow surgeons to focus on retrieving knowledge which will be retained in a database rather than in a personal memory. So in the hospital, we have got everything about the patient in a hospital information center, your data center, and you can access it on the table itself. This will translate the art of surgery towards a science capable of duplication. You might have heard about the Google's camera putting on the glass. In the glass while operating also many years ago developed, and you can find all the information about that thing. And also now with the ChatGPT, etc., you can put a question and get the answer while doing a surgery. Now, familiarity with AR, VR, and mixed reality and extended reality XR technologies will facilitate rehearsal using head-mounted display in a metaverse environment. You might have heard in a couple of days newspaper happening fight between the metaverse groups and the Apple group that which is the best head-mounted camera display, you call HMD. So here you can really practice surgery, and you can also perform a surgery, and you can also you can do a lot of things. You just have to think what you want to do it. Everything is possible. You might have heard about black box in the flights, flight recorders. It is very informational when the flight get accident, so that they can retrieve data. It is just like a OR black box. This is already in practice, where all the event in the operation theater, like Professor Parikh has said that your mobile phone is off, but still you have all data is happening there. And people say, don't keep mobile phone near when you sleep or in your bedroom. Because that's the same reason all these data are captured. So here the black box records everything happening in the operation theater, and any mishap, the government will ask you, please give us the black box to investigate. The OR black box can provide objective, quantifiable data from the OR to the stakeholders, but also so they can perform detailed root cause analysis to identify overlooked intraoperative factors that may have impacted the clinical outcome. Today, you might have seen many things happening in the National Medical Commission, finding some hospitals, some wrong procedures, everything. You don't have to have that kind of thing. You have just black box recorder, you get it, and all the data are authentic, and the objective way you can penalize the people. The same process can be used assessing trainee surgeons' skill using surgical video data analytics. This is a very important topic for surgeons or for any interventional procedure. Now, every medical department also has interventional component. So how can you train your people? How can you assess them? It's a big area for investigation. So this is possible through this kind of thing. Even AI also talk about these things. You can really train them using AI technologies. A new chapter has come, a new specialty has come. Madam may take a note of it, surgical data science. It is all basically the data generated during surgical procedure or any interventional procedure. When you talk of surgery, please interpret as any interventional procedure. Gastroenterologists do a lot of intervention nowadays. Cardiologists, every medical specialist are doing some kind of intervention. So all those data are very, very important for not only for learning process, also for investigation purposes and doing research purposes. This terminology is very old terminology called computer-assisted surgery. Today, we have got precision surgery. You might have heard about precision surgery, precision medicine. All these things possible because we have that grade of kind of technology available where a nail in the spine can be put with a computer guidance. There are robotic arms. They fix the nail in a particular space without any human kind of skill there, actually. So the computer-assisted surgery consists of a group of surgical procedures and computational tools for planning, guiding, or performing surgery. This will you see in the coming generation more and more. This system guarantees minimal invasive surgery, thus producing tissue damage, pain, and reducing hospitalization. Whatever you're doing, laparoscopic surgery or any keyhole surgery, that's all because of this computer-assisted surgery. Also increase the accuracy of surgical procedures, providing additional complementary tools for the surgeons. Now, how to visualize your operation theater in the future or your interventional suite in the future? The operating room of the future epitomizes those current and future enhancements that can contribute to the patient safety in the operative environment. Remember that all this that we are doing, whether in medical discipline or surgical discipline, patient safety is the paramount important. Here, AI is going to play a big role in that. So you have the new terminology coming up, cognitive computing. So you can do a cognitive simulation, smart imaging, informatics, smart environment. All these things that you heard from Madam Mehtal also is not so foreign and not going to be foreign in the future. We talk about cognitive therapy for mentally ill patients. So all these things are the future and that all be applied to the operation theater. Just a new term I want to introduce to all of you called digital twin. It is just like making a twin of anybody. Today you just saw a video. It is just like a twin of Dr. Shashi Tharoor. So you can make a twin of a hospital. You can make a twin of Mahatma Gandhi Institute also. All those technologies are available now. And you can make a twin of a particular patients with a particular disease and plan your surgery. And all these things are possible now. We call digital twin in surgery. I'm not going more into that, the shortage of time. And this surgical training is also going to the digital age. We have already achieved many things and video-based education, etc. Now today you got anything that you want to do just in YouTube or anywhere you find it in mobile phone. Your mobile phone is just not a phone, it is a smart computing. Professor Parikh, I just told you, just make it a smartphone. Not ordinary phone, but smartphone. Any smartphone available so cheap, we can really make the utility of these things. So that is the training that you got in the surgical age, information age, is to access more and more information in your handheld computing devices. So that is the digital learning platform. Easy access now available. Many things are available in public domain free of cost. Good quality content are there. And with virtual reality and simulation technologies are already there in more and more being practiced. Take the help of that and then you can train yourself. Don't have to depend on many big surgeons do it. A new terminology is coming up. You will see more and more in the future, like industrial age 4.0. Currently, we are passing through all these 5G network, etc. in the part of these things. So this term I want to introduce to you, just a few bullet points. Surgery 4.0 is the natural culmination of the industrial evolution. Surgical data science is part of this. Surgical process modeling, cognitive surgery, surgical data processing for a smart intraoperative assistant system, digital communications and social media used in surgery, how to maximize communication in the digital age. All these things you can do it yourself, just your thinking matters. Intelligent digital assistants for clinical operating rooms. So you'll find the AI assistants are going to be there for future. There are many social ethical issues, and you don't have to present this thing, you all know about it, what is going to happen in the future. It is going to create a lot of problems. The AI is going to get a lot of problems. So let us face that. Let us prepare ourselves. I'm not going into detail about that. So just remember, any new technology comes, there are ethical issues. Just to conclude, surgery 4.0 does not mean that robots will perform surgery. This can neither be the vision for the surgeons, nor would be accepted by majority of patients and societies with a highly developed healthcare system. However, AI, robotics, model-based surgeries, and many additional principles of surgery 4.0 will certainly help to make surgery more evidence-based, safer, and easier, all with goal of better outcome and experience for the patients. So thank you for your kind attention.
I'm extremely sorry we are running late, but this is an interesting topic. So being a surgeon, I have a bias towards AI in surgery. So we have international expert, Dr. Andrew Gums, who's a surgeon. He's also the editor of a journal called Artificial Intelligence Surgery. He's joining us online. Can we please have Dr. Gums?
No problem. I know we're running late. Thanks again for the invitation. We'll jump right into it. You should by now know the title of my talk. My disclosures we won't go over. This is where I do my artificial intelligence research at the University of Magdeburg in Germany. Just an overview of what we're going to talk about. We're going to briefly mention the Artificial Intelligence Surgery Journal. We're going to talk about definitions of autonomous action. We're going to talk about the Ergos project and what Surgeomics means. And lastly, we're going to talk and show a little bit of what AI already exists in surgery. So this is the journal. The website is AISJOURNAL.net. First issue came out just over 2 years ago. We're on volume 3. Issue number 4 came out in December. We're about to start volume number 4. Our impact factor right now is 3.47. We have applied for an official impact factor, and we anticipate getting that officially this year. So what is surgery in 2024? I have to change this slide, but it's basically a mixture of open surgery, minimally invasive surgery, but also interventional endoscopy and interventional radiology, or what we call surgical endoscopy, okay, and interventional surgery. So some other speakers went over about the nuances of what artificial intelligence is, like machine learning, deep learning, computer vision, and robotics, so I'm going to skip through there. We're going to talk quickly about how the publications of artificial intelligence in surgery peaked back in 2013, dropped down in 2017, but as you can see here on this slide, they've really started to peak up again. And if you go even a little further, I have to update this slide also, but it's really gone off the charts. And that lull really followed a dip. That dip that we see followed the development of artificial intelligence over the last, I would say, 11 to 12 years, with the development by computer scientists of machine learning and deep learning, which is why what we were dreaming about over a decade ago is now possible today. So these are just some images of augmented reality that, again, I don't have time to go into. And these are just some other nice, beautiful images. This was published in Cancers from Patrick Passot's group at EARCAD. But I do want to show you quickly Jarvis. Jarvis, or the surgeon's Jarvis, it comes from a character of Vision, which is from Iron Man's Artificial Intelligence. That's the name of his butler. But I just want to show you this application. The surgeon's Jarvis that you can download on your phone. It's been available for over 5 years now. And we're just going to show you the video. So you can imagine you're a young surgeon, you're doing a difficult cholecystectomy, it's 2 o'clock in the morning, your boss is asleep. You ask your scrub nurse, your circulating nurse to take your phone, turn on your camera, and you can do a video of the laparoscopy screen. And as those red lines turn from red to green, it'll essentially be telling you, using computer vision, that you've obtained a critical view of safety, and you can safely clip your critical structures and cut them. Now, why am I mentioning this? Because you can imagine in the United States, if you have a common bile duct injury and the lawyer for the prosecution, they find out that you didn't use this technology that has been available for over 5 years, it can be a problem. So am I saying we need to use this for all of our gallbladders? No, but I am showing you that artificial intelligence does exist already, and they're products that have been around for a very long time. So in the interest of time, we're going to jump to the Ergos project, which is another example of artificial intelligence used by surgeons. Ergos stands for Artificial Intelligence, Genomics, Radiomics, Oncopathomics, and Surgeomics. So this is the workflow right now that we all know for cancer patients. We rely on preoperative imaging, biopsy results, the pathology from the surgeon, from the surgery, and using that, we decide what chemotherapy to give patients, either neoadjuvantly or adjuvantly, or what have you, when to give radiation treatments, et cetera. Now, what if we use artificial intelligence? You know, radiomics, or all omics, comes from the Greek word that means whole. So what happens when we look at all of the data points from a CT scan? When we look down to the pixels, okay? This is a study that looks at a hepatocellular carcinoma, looks at a single slice arterial phase for hepatocellular carcinoma, looks at the largest slice, and they compared patients who survived for less than 2 years to patients that survived for longer than 2 years. And they're able to create an algorithm that, going forward, is able to predict patients that will have poor prognoses as opposed to patients that will do well. All right, so why is this important? Traditionally, when we look at a CT scan, we just want to see if the tumor is resectable or not. Radiomics enables us to tell us not only is the tumor resectable, which is really is secondary importance, but whether we should remove it in the first place. So the computer, using radiomics, can go down to the pixel level and tell us this information. This is something that the human eye and mind cannot comprehend. It's too much data. This is known as the black box phenomena, but this is a fundamental part of the power of artificial intelligence. Now, what happens if we combine, I'm just going to skip here. What happens if we combine artificial intelligence or this concept not only to radiomics, but also to genomics? Instead of using just looking at 500 or so genes that tumor panels have, at Memorial Sloan Kettering, they have what's called MSK Impact. It looks at 505 genes. But what if we look at all the genes, the entire human genomic sequence? We can now get that information for about $1,000. We can look at all 20,000 to 25,000 genes, all right? We can look at the radiomics, like I just told you, where we look at not just one slice, but we look at all the slices of the CT scan. We look at the 3D reconstruction. We look at the arterial phase, look at the venous phase. Then we look at the pathology slides, look down at the pixel, and we can get information there, again, that we can't comprehend. Now, we teach the algorithm by putting in what patients' chemotherapy they got preoperatively, postoperatively, immunotherapy, their schedule, when they got radiation, if they didn't get radiation, et cetera. We train the algorithm, and then going forward, we no longer have to guess. We can tell people what chemotherapy they should get, what chemotherapy they should not get, when they should get it, immunotherapy, whether they should get surgery, everything. So the dream or the goal of Argos is to create a truly personalized medicine for cancer patients. And if this paradigm works in surgery, in cancer, we can extend it to inflammatory diseases, Crohn's disease. We can extend it to all sorts of different diseases that surgeons treat. In addition, once we've created this, we also want to look at surgeomics, which I kind of skipped this in the interest of time. But what about the data from the video in the operating room? What if we can look at a critical part of the operation and get information that, again, can make the algorithm even more powerful, okay? So this just talks a little bit briefly about what surgeomics is. It's essentially omics of the video recording of the operation itself. Now imagine if you have ICG, if you use narrowband imaging, if you use hyperspectral imaging during the operation, imagine the amount of data that we can generate, okay? So obviously it's too much data for us to generate now. We can only look at part of the operation or what have you, but the future is we should be able to get real-time information. Maybe the computer will be able to tell that, look, this tumor is resectable, but while we're operating, the computer can tell us, look, don't operate on this patient. The patient's not going to get any benefit. That's the ultimate idea of Argos. That's the S in Argos, the surgeomics part. So this is just an editorial that talks about the second phase of my talk. I want to talk about autonomous actions, okay? Artificial intelligence surgery. When I talk about artificial intelligence surgery, I'm talking about autonomous actions. When I'm talking about artificial intelligence in surgery, I'm talking about things before the operating room and after the operating room, things that Argos would help us with in, like with tumor boards and things like that. So a lot of people don't understand artificial intelligence surgery. They think that to have this, the robot has to do everything. Otherwise, it's not artificial intelligence. It's not that simple. We have weak artificial intelligence, which are really just automatic actions. You push a button and the action is just done. And then you have strong artificial intelligence or autonomous independent actions that are done by a device. The best way to understand this is by looking at the 6 levels of surgical autonomy based on the 6 levels of an autonomously driving car. Level 0 designates no autonomy. Level 1 is defined as telemanipulation of a robot, which is really what the Da Vinci does. It's just a remote control, very low level of autonomy. Level 2 corresponds to limited autonomous action. Level 3 is conditional autonomy, where the surgeon selects from several different buttons, essentially, or options that the device or robot can perform. Level 4 includes automated medical decision-making, still under a doctor's control. And level 5 indicates full autonomy, no doctor's input is necessary. So the best way to understand this is to give you examples. Level 2 autonomy, the Signia stapler. It is a linear GIA stapler. It has a sensor. When the tissue is too thick, it'll slow down as it cuts to make a safer staple line. If it's really too thick, it won't fire at all. And if it's not thick enough, it won't fire. So this has a sensor. It interprets data, and it makes some element of autonomy. Another example is the integrated table motion, the Trumpf Medical. As the table with the Da Vinci moves on the latest model, the 4 robotic arms move at the same time. Okay, so that's actually the thing that impresses me the most about the Da Vinci is the table. And as the arms move, as the table moves, the arms move. Okay, so what about level 3, ligature? This is a vessel sealing device. It uses an advanced vessel sealing algorithm. It analyzes 434,000 data points per second. You have 3 different buttons, depending on how large you think the vessel is. And the device tells you when it's safe to cut. You don't make that decision. And this has been around for decades. So this is an example of level 3 because of the 3 different buttons that you have, okay? Now, level 4, I'm just gonna tell you quickly, is when an interventional cardiologist snakes up a catheter, trying to do an ablation, goes into the right atrium. The device, once it's in the right atrium, it detects the area of the ablation and it gives the ablation. The cardiologists really are just sitting there while the device does it itself. So if I had time, I would ask you, does level 5 autonomy exist in healthcare? And the answer is yes, of course. AICD, automated implantable cardioverter defibrillator, a pacemaker, what have you. It detects a life-threatening problem, and it gives a life-threatening treatment with no involvement of a human. So level 5 autonomy has been around for, decades already. So really, it's strong AI, no human control is needed. So we really need to stop thinking that AI is far off in the future. If, AI is here, high level, full autonomous actions. So this is a white paper talking about the definitions of artificial intelligence and autonomous actions in clinical surgery that was published in our journal, I believe 1 or 2 years ago, if you're interested in this topic. But in the last few minutes, I just want to talk about robotics, okay? Most robots, surgical robots right now are just telemanipulators. There are over 70 robots right now. I'm not going to go through all of them, but basically they're grouped into ones with multiple arms, single port, and lastly, endoluminal ones. So you have the Da Vinci. It has a single base, the current model. You have the Mantra in India, separate bases for all the different robots. You can have up to 5 robotic arms. Here's the Versius, similar to the Mantra, Avatera, Bitrack, Senhance, Hugo by Medtronic, Dexter. Then you have the single incision ones. Here's one from Intuitive, here's Vicarious, here's Enos, here's Mira, and then you have endoluminal ones. Now, why am I putting these out? These are all just telemanipulators. So these are all very low level of autonomy. So what is the future of robotics, and how do we get to more autonomy in surgery? And the best way to explain this, or at least I think, is to look at Star Trek or Star Wars. Do we want the surgeon at the bedside, like in Star Trek? This is Next Generation. Or do we want it like in Star Wars, where there's no human involvement whatsoever? There's just a robot, and there's just some poor person screaming on an operating room table as these robots operate on the person. So we wrote a paper about this, looking about keeping surgeons in the loop. We looked at handheld robotics, and we looked at colorectal metastases and whether you remove them with handheld robotics or with the Da Vinci system. And we found some advantages when we used handheld robotics with with the surgeon still at the bedside, okay? So here are some examples of handheld robotics. This is by Jamie. There's also a company in Israel called Handex. So you have 7 degrees of freedom. You have haptics, you're holding it in your hand. You have an autoclavable laparoscope holder. This is by EndoControl. And then you have the stapler that I showed you. Now, what about more collaborative robots or non-console robotics? This is the Maestro system by Moon Surgical. This is the surgeon operating with the assistance of 2 robotic arms. Right now, you can see the surgeon here, he's just using laparoscopic instruments, but imagine, again, he's holding those more advanced instruments I showed you, like the Jamie or the Handex, and now imagine two robotic arms holding those devices, so when the surgeon lets go, the arms stay in place. You have some viscosity, you have some stability. So this is just another way that we need to start thinking about robotics. Maybe this is the best way to do more complicated surgeries, more vascular, more tumors that are stuck to big vascular structures. So I think in the future, a mixture is probably probable. I think the Da Vinci or telemanipulators are particularly good in the pelvis or what have you, but we need to do more research in non-console robotics. We need to think about handheld robotics so more people can benefit from robotics. And just so we understand what is available so far in robotics, we have vessel sealers, we have staple anastomotic lines that have intelligence, we have automatic needle placement, motion scaling, tremor reduction, organ segmentation, and autonomous laparoscope tracking. We also have autonomous aspiration, retraction, debridement, and suturing, the STAR robot, which a lot of those studies are being done at Johns Hopkins. But we also now have situation awareness, is there bleeding going off in the side, and phase recognition, so the computer has memory what part of the operation we're doing. It's actually difficult to do that, but there are actually prototypes that are being developed that are able to have the robot understand what's happening. And I'm actually working with a company in Germany on autonomous pneumoperitoneal access. The one thing we still don't really have is autonomous dissection. I think that'll be the most difficult thing to automate or to make autonomous, but people are working on that already. So this is just a Gartner Hype Cycle. It follows that graph I showed you of publications. I don't have time to go into the details of this, but the discussion of this is published in Sensors on Autonomous Actions, published a few years ago if you're interested. So just to wrap up, current AI includes, machine learning, natural language processing, computer vision, deep learning, like we talked about. Algorithms like Ergos have the potential to give us truly personalized medicine in our lifetime, which is amazing. We can stop guessing. And surgeomics is a field you need to start to pay attention to, especially if you're a surgeon, because it combines AI with intraoperative video data and may be the best way to keep surgeons in the loop, in addition to handheld robotics and non-console robotics. So thank you very much. I know it's very late for everybody. If you have any questions and if we have any time, I'll be here.
Thank you, Dr. Gums, for joining even at such a late time. I once again apologize to everyone for the delay. I have one more bias, that is towards my former students. I have many of them illustrious ones, including Ajay, who's sitting here in the audience, Dr. Ajay Sharma. So another of my former students is Dr. Biju Potakat, who's the chief of GI surgery at JIPMER Pondicherry, but he's here because he recently organized a national level conference on AI in diagnostics. So I requested him to just make a couple of comments. Biju, please.
Yeah, good morning, Dr. Gums and other faculty. So when we did works in AI, one thing what we immediately realized was the sensitivity is high, specificity is low. It is dropping, especially we work on artificial intelligence liver imaging. The specificity drops to somewhere at 74-75%. Across the spectrum of AI in medicine, this phenomenon happens. And unless we increase the specificity of all this interventional diagnostic modality with respect to AI, there will be a challenge. Second, another issue we are facing is the AI turbulence now. So now we are living in a AI turbulent area in medicine. We are going to see a lot of innovations, lot of companies are involved, and technology is slowly picking up in this field, but not mature, that we have to realize. One of the very good example is the Da Vinci robot and Mantra. So the Da Vinci is very costly, high AI programs, but Mantra is 1/5 of the cost. Now the AI companies are invented those systems, are unable to integrate it with the Mantra. So these sort of issues we are going to face in real time. And I think in the turbulent period, we have to be really patient and mature, and a lot of this competition, capturing the market, canvassing the surgeons, and making a product artificially superior to another product is there already. We should be really, really cautious about this industry canvassing, especially in the field of AI. The virtual histology, virtual imaging techniques, all are there, but we have to realize that the specificity is still not, many of the technology specificity is still not up to the mark. So if we think that in 2 years our histopathology slides are going to disappear and all that, no, it's not going to happen. These are the few comments I wanted to make. Thank you very much, sir. Thank you.
Thank you, Dr. Biju. May I now request Dr. Munish Kakkar, who's the coordinator for the clinical combined rounds, to for a vote of thanks.
Good morning. And it was really Gagar mein Sagar on artificial intelligence. Our eminent speakers were kind enough to provide us whole day CME in 1.5 hours. So my sincere thanks are our Honorable Vice Chancellor Ajal Gulati sir, Pro Vice Chancellor Kapoor sir, and Emeritus Professor G.N. Saxena sir for organizing such wonderful CME at platform of the combined clinical round. Words will be short to express my gratitude to fatherly figure and legendary professional Emeritus Chairperson M.L. Sonkar sir, who is the guiding force since the inception of the CCR in 2017, who is providing us kind support and physical presence in each and every CCR, whatever is organized, and even he is present today. So it is a really moral boosting for all of us. Thank you very much, sir. We are thankful to our Honorable Chairperson, Vikas Ji Sonkar, and management for providing us unconditional support and whatever and whenever we needed for combined clinical rounds and academic improvements. We are, on behalf of Mahatma Gandhi University of Medical Sciences, we are extremely grateful to our speakers, Namita Mittal Madam, HOD Artificial Intelligence, MNIT Jaipur, SK Mishra sir, HOD Endocrine Surgery from SGPGI Lucknow, and Andrew Gums from Georgia, Dr. Potakat from other parts of the country, and Purvish Parikh sir, HOD Clinical Hematology, who enlighten us with wisdom words and from the basics to all what is happening in artificial intelligence. We are thankful to eminent faculty members and students present here as offline and online and attending this session. We are thankful to all the technical staff and all the members. Thank you very much.
That brings us to the close of the combined rounds. May I request patrons and our speakers for a group photograph? And I would request Dr. Swati ma'am, who was the former principal of the medical college, to felicitate Dr. Namita. Yes, yes, sir. Dr. Gums, thank you very much. I know it's midnight for you. Please, if you wish to log out. Thank you very much.
Thank you very much. Good night.
Good night. Good night. Thank you.
Have a good
Thank
day,
you.
everybody. Thank you.
Thank you. I also request the patrons to please launch the book Oncology for Physicians, which has recently been published by Dr. Hemant. I'll request him to say a few words.
So thank you. I think let's give a big round of applause to Dr. Kapoor for organizing this wonderful CME. We are very acutely aware that we are very, very late today. Just take 2 extra minutes. Dr. Parikh and myself have edited this book titled Oncology for Physicians under the auspices of the Indian College of Physicians and the Association of Physicians of India. And this is going to be available to each one of you who is interested, maybe not the hard copy, but we'll certainly provide you the QR code to access the whole of the book. And today, just after today's work, Dr. Parikh and myself will be leaving for Delhi to go to the API to get this launched over there.
Just a small announcement. On 24th, this Saturday, we are having a half-day CME program conducted by Dr. Subramaniam Iyer. Now, Dr. Subramaniam Iyer is Chief of Reconstructive Surgery at Kochi, Amrita, and he's the chap, if you've noticed in the newspapers and all over, the first person to do the bilateral hand transplant and the first person to do the single hand transplant, all of which are working hands at present. So he'll be presenting on facial-maxillary reconstruction, head and neck cancer, and on facial nerve reconstruction. So it's going to be a very interesting thing, and we are fortunate again to have Dr. Subramaniam Iyer over here for that talk. So please make it a point to attend in case it's possible. Thank you.